Good morning. I'm Dr. Johan Baguilat and welcome back. At this moment, we will now have the last part of the didactics of the training course. So we will have the last two lectures for today, which is the anatomy of an endoscope and the principles of endoscopy. So to start with the anatomy of an endoscope, let us welcome back Dr. Ray Sarmiento.
Thank you, Johan. So, Dr. Arlyn and I will exchange the lectures kasi medyo kailangan ni Arlyn bumawi muna. Okay, let me go down to the anatomy of the endoscope. And we all know that the endoscope is a platform wherein we are able to visualize the inner structures or the inner or the lumen of the GI tract. So, with laparoscopy, we try to visualize the extraluminal side of the GI tract. With endoscopy, we visualize the inner lining or the lumen of the tract. And of course, if you have an endoscopic ultrasound, it will be able to visualize the layers of that tract. So it's a very useful tool to have in your armamentarium as a general surgeon. And this is how it would look like, the new generation of scopes. And I'll deal with it later on, part by part, or break it down slowly. But it did not start that way. It started this way. It's a very crude instrumentation where they use the candles or reflected light as a light source and be able to use it and peep through holes without even use of lenses. So just taking a look at small cavities. And if I'm not mistaken, one of the it's like one of the first cavities that were investigated were the bladder and the vaginal cavity. So from a rigid scope like that one, wherein you see it's like a sword swallowing thing, like the magicians they see on TV. It has evolved into what we have now, like a flexible endoscope. So that's why you would see some of our older or elder surgeons do like this. Nasilip mo na ba? Because that's the way they were exposed to, no? Instead of nasilip mo na ba? The action that we now use is nasilip mo na ba? But before, nasilip mo na kasi the exposure then before that they before the flexible endoscope is that way. They're using a rigid scope. And then actually there came a time that it's just an eyepiece without any camera monitor. Patients were seated this way, and actually I was um, I was able to encounter flexible endoscopes that uses fibers still. So there's no CCD camera at the tip of the flexible endoscope. They still have to attach like an eyepiece to that flexible endoscope to be relayed into a monitor so you can see what's inside. So when those fibers get broken, you'll see small peppercorns on the screen. Those are the old type of scopes that we had. And if you want an observer to see how you do the what he sees, if you cannot, uh, uh, put it on a screen, they would have a separate eyepiece for themselves. And even the camera that they use to take pictures for what they see inside, it's a shutter camera and attached on the top of the flexible endoscope. But anyway, because of as technology improves, we have this tower now, and it's a flexible endoscope, as we call it now, or as you see it now. So what is important is to know your system. Of course, it's broken down into monitors, video processors, a universal connector, and actually the system that we have now is a newer system, but you will see it later when you do the labs. But before the X1 and the S700, there's a 190 system wherein you can use both for flexible endoscopy and laparoscopy, just different attachments for the camera head for laparoscopy and a different attachment for the flexible endoscope. So in the country, we have a 100 series scopes. In different countries, it would be a 200 series scope. So you cannot interchange those systems. Japan and Europe has 200. North America and us have 100. 100 also in Hong Kong, or 200 series system. A 100 series, a 100 series also in Hong Kong. So you cannot buy a machine from Europe, a very cheap one, and then get a 100 series. They won't read each other. It's like the old TV NTSC and the PAL system, PAL-SECAM system. They won't match. So the scope is divided into a connector, an umbilical cord, a control handle, the insertion tube, and the bending section. Make some tayo, ha? Tandaan nyo to. Joke lang. So there'll be an exam after this. Ayaw tuloy mag-move. Okay, so the connector, if you see the connector, this is the new generation connector. You just attach it to the system. But before, it's separated into one into the camera system and one into the light source system. There's what we call a pigtail connected to it. But this one, everything is connected into one rod. I mean, one series of connection, and it's watertight. There's a portion here wherein after every procedure they check for air water leaks. I mean leaks inside the tube of the scope, because our lives as endoscopists, or if you as a minimally invasive surgeon, wherein you use, or this one is of use every day, we have to take track of how it is maintained. Because once it's broken down or destroyed, then wala na tayong, we don't have anything to use. So we take care of these scopes just like we take care of kids or our next of kin. So it's divided into light guide, our air water connector, S-cord connector. This is for the cautery, but we seldom use that. Suction connector, auxiliary water jet, and the venting connector. So the control handle, so this is the grip section. This is where you put your hand. Some would put 3 fingers on this grip section and then toggle their pointer from suction to air water control and even along the knobs. The big wheel is what we call the up-down control. The small wheel is the left and right, and then there are locks. So free, and then you twist this to the right, it's free. It's the lock. It can move up and it can move forward and backwards. And then you rotate this small handle to lock the small wheel. So this lock is for the big wheel. This circle here is the lock for the small wheel. The small wheel is for your left and right control. The big wheel is for your up and down control. Actually, the up and down control is just to actually center the bending section of the scope for you to be able to visualize the whole lumen. It doesn't really follow in a manner if you really put it down, it will go down. It's actually, there's a lot of movement associated with body movement, shoulder movement, torquing of the insertion tube. That would give you the precise visualization of what's inside the GI tract. So air water valve, just press on it. It will put out water. Deep press would put your finger on top of the hole, cover the hole. It will be air. Press on it, it will be water. And then this is the instrument channel port. This is how it looks like, front facing. Now, the control handle has several buttons wherein you can program them according to, and we call them remote switches, according to what you want to put there, like capture image, near focus, freeze unfreeze, and narrow band imaging. So it's reprogrammable according to the unit where you are working. The insertion tube is the one that's longest, and it's covered by a polymer soft resin, then a hard resin, and then metal stainless steel wire inside. Of course, this protects everything, what's all the electronics inside, so that it doesn't get wet. And of course, the length and diameter of each insertion tube varies from upper GI to lower GI. So the bending section is the one that actually moves when you do your up, down knob, or the left and right knob. And then, of course, there are additional movements when you put your big wheel up and then you torque your scope. It will, the view will be different when you do that. So these skills or these maneuvers are not innate to us surgeons because we were not taught that those skills early in our surgical training. We were only taught to zoom in and zoom out as trainees for the laparoscope. Left, right, and then when the 30-degree came in, we were taught to zoom in, zoom out, 9 o'clock, 3 o'clock, 11 o'clock. So those were the skills that were taught to us during our surgical training. So the bending section, so there's like a pulley, a long pulley inside, wherein if you twist or, I mean, you turn the knob, it will bring the bending section up, and the opposite side will bring the bending section down. So that's how it works. So we have to protect that with this resin so that it doesn't get contaminated with water, since water causes erosion and damage to our electronics. And the distal tip is composed of these small circles. The objective lens, that is where the image is processed and then relayed to your monitor or your central processing unit, and then it is displayed in your monitor as images. There are two light-guided lens, an air-water nozzle, meaning air will come out here once you press on the air button, and if you press deeply, water will come out to wash off the lens. And then this is the auxiliary water channels. Some may have, some may not have. The 180 series doesn't have auxiliary water channel. Once the 190s came in, then you will have this auxiliary water channel. And then, of course, this is the instrument channel. And there are varying diameters for this, from 2.8 millimeters to the largest one, 4.2. So doon na base yung naririnig nyo na 2.8, 3 point, at a 7 French tube will not go inside the 2.8 millimeter channel. Sorry. It will go through, but very tight, because it's 2.8, it's 2.3 for 7 French. But a 10 French tube will not go through a 2.8 channel. So you'll need at least a minimum of 3.85 channel, and then 4.2 will be the easiest. You might even be able to put 2 6 French tubes in a 4.2 channel. So if you go to Chicago at the ASG, or the American Society of General Surgeons Training Center, it's like a PICAS for endoscopy training. Under ceiling, their chandelier is something like this. They have 3 lights and then 2 eyes in the ceiling. So that's a training center for endoscopy also. So please do log on to that site so that you'll be able to see what courses they offer also. and then you can go to Chicago at the Downers Grove, and then it's like a PCAS for endoscopy. So what is important with endoscopy is, of course, you choose your weapon. When you do your upper GI endoscopy, you use a gastroscope. Of course, when you do your colonoscopy, a colonoscope, it's the diameter is a lot bigger. But there are certain scopes that have different stiffness from 0 to 3. But I don't think. Do you still use the stiffness of the no the stiff no more, right? Because of the skills, you are able to reach 100% all the time the C-cone without actually using the stiffener for the scope. An endoscope is a longer scope, smaller in diameter, but would need an overtube to be able to at least reach part or a major portion of the small bowel. It's either top or bottom. A duodenoscope is your side viewing scope. That's what we use for ERCPs. And then the echo endoscope, there are varying types of echo endoscope. There's even a radial and a linear echo endoscope, and a linear that's actually forward viewing. Usually, echo endoscope is an oblique viewing scope. Of course, choledocoscope is part of our armamentarium as a general surgeon. It's just an up and down uh, movement, but the rest of the movement of the scope depends on the risk and the torquing of the insertion tube and the bending section. This is where you put your suction, and this is where you irrigate and then put down your baskets or your snares to get those stones. Another would be okay, this is a series of, I mean, Spyglass DS is a scope that you go put through in duodenoscope to be able to go into the CBD. It's the prototype of this, or the mother of this, is the mother baby scope. The mother baby scope is the problem with the mother baby scope. The baby scope is so fragile that if you're going to use the baby scope, the Olympus baby scope, once it passes the elevator of the duodenoscope, you'll have to repair it, and it's very expensive. So they came up with these disposable scopes. And in the market right now, if you go to conferences, there'll be upper GI scopes and even duodenoscopes that are disposable because of the problem of infection and what they call a reprocessing. So some countries would advocate using one EGD, use it to one patient, dispose it. One duodenoscope, use it for ERCP, then dispose it. I think the only problem with that is, since there's no reprocessing, it might be cost effective for some centers, especially very high volume ones. Problem would be the footprints, your ecological footprints, because you have to throw that waste in bulk. So it might be costly for the hospital, especially if you're weighing your disposal, it's weighed in tons, and you pay a third party to get that waste for you. So they are they are still thinking if it will be worthwhile to use a disposable scope. Even in anesthesia or pulmo, they use disposable bronchoscopes for intubation or even bronchoscopy. So this is a small scope. This is a 10 French scope that can have biopsy, laser coming out, or EHL catheter coming out. So for your accessories, basically this is what we have: guide wires, forceps, snares, baskets, cytology brush, stents, and there are certain indications when not to use these accessories to help you with your treatment or diagnosis of certain diseases um, in the GI tract. For hemostasis, just an example, we have needles and clips and rubber band ligators, bipolar catheters. So there's a gamut of catheters that we can use to be able to deliver uh, therapy in the most minimally, in close quotation, minimally invasive way through the endoscope. And then closure of perforations clips and over the scope clamps are now being used. Of course, those are, we can teach you that later on. Because what is important is basic scope handling. And then the accessories or when to use it for certain disease entities, then that will be advanced training. I'll pass on the mic to Dr. Baguilat.
Thank you, Dr. Sarmiento. Okay, so we move on to the last lecture for today. So to introduce our next speaker, she is currently the training officer of the Rizal Medical Center, Surgical Endoscopy and Minimally Invasive Fellowship. She's an assistant professor in the La Salle Medical and Health Science Institute, Department of Health Informatics, and the Department of Surgery in Dasmariñas, Cavite, an active professional staff and the section chief at the Asian Hospital and Medical Center section of Surgical Endoscopy in Alabang, the co-director of ELSA Outreach Program Flexible Endoscopy Task Force, and a member of the Asian EUS group. So she will be giving a lecture on the principles of endoscopy. So, ladies and gentlemen, please welcome Dr. Arlyn R. Cañones.
Okay, hello, good morning. So the previous lecture actually is part of the basic endoscopy lecture give to ELSA. We have actually an outreach program for basic endoscopy, and that's actually part of the this lecture. So I will not repeat the lecture that was given by Dr. Sarmiento earlier. So I will go to the principles. All right. So I'm sure everyone had your hands-on yesterday. Did you enjoy your hands-on? Okay. Bitin, no? All right. So bitin ba? But everyone had prior exposure to endoscopy before, or that was the first time? You had. Most of you had exposure to endoscopy before? You've done endoscopy before? Okay. So I'll just run through the indications for endoscopy. So for specifically for upper GI endoscopy. So if you want to see the whole list of the indications for endoscopy for upper GI, just look for the ASGE guidelines. But basically, it's for bleed, dysphagia or odynophagia, persistent vomiting, screening for malignancy, caustic ingestion and foreign body ingestion. So it's, just like in the video shown, this is rubber band ligation of your esophageal varices. But for us surgeons, what is important is the intraoperative assessment of your anastomosis after your esophagogastric anastomosis or your gastric anastomosis and localization of your lesion or tumor, especially if you want to do your combined Endo-Lap surgery. And of course, as part of your competency as endoscopist, you should also know how to assess your post-operative complications like your anastomotic stricture, your bleed, and your leaks. And if you can do management for those, of course, that be a plus as well. So how do you do your EGD? So first, EGD, the proper, what you call this, systematic way to do it is, of course, to check your esophagus, your stomach, and your duodenum. So how do you hold your scope? Your scope is held by your left hand. So just like that. And the umbilical tube is in the inner part of your arm, so that you can you have freedom to use your wrist. See, it's just like in the picture. So where do you put your fingers? So as was discussed earlier by Dr. Sarmiento, me personally, I use the 3 fingers holding the body so that my index and my thumb is free. So the thumb, I have small hand. So I use my thumb to manipulate the big wheel and the middle finger to do the up down. So it helps the thumb to do the big wheel for up and down. For the small wheel is used for your right and your left. So sometimes I can use my fourth finger, but it's not that long, so I use my right hand. So that's still okay. Your index finger is for your suction. So that's the first one, the red one. And my middle finger used for your air and water. If you press the second button, the blue button, that is for your water. If you just cover, you insufflate with your air. So what we always tell our trainees, you have to check your equipment. Do not rely on your assist, on your nurses. You should check your equipment. So of course, you have to check your monitor, your video screen, check that your name is in there, your patient's name is there as well. The bite block or the what's the other term for bite block? B- Mouth guard. There you go. Mouth guard. If you're going to do EGD, most of the time this is under your local light sedation, so you can spray with lidocaine prior to insertion of your scope. And of course, the scope itself, you have to check for your light, for the light and the buttons if the buttons are there. Because sometimes they just give it to you and then you don't know that if it's complete or not. So for EGD, the position, this is the proper position. Patient is in left lateral decubitus. You stand at the left side of the patient and you're facing the screen or the tower. So most of the time, the screen is included in the tower. But in some institutions, they have two screens that can that you can view the endoscopy. Okay, so insertion of the scope, of course, you have to start in the mouth. As you can see, this one, the bending tube, this is the bending part of your scope. So the last 10 centimeter of your scope is the bending part. You bend it to follow the curvature of the tongue, okay? And then you insert it slowly, follow the tongue until you see the epiglottis. So look at this video. So until you see the glottic, and of course you go to the other side to the CPJ. But prior to doing this, don't press your water or your air yet because the air and water might go to the trachea, of course, might cause aspiration. If you need to suction the mucus or any fluid, then you can suction lightly. So there, this is the CPJ. So once you go there, you can also go here, but I prefer to go here. So once you already for looking at the CPJ, you can use your air to help open up the CPJ or cricopharyngeal junction and then push your scope slightly. For the beginners, when you say torque, you twist the scope. Okay, you twist the scope. So you twist it to the left. Although sometimes we tell the trainees to twist the body like this to the left. Kasi the effect would be the scope turning to the left as well. So always keep your lumen at the center. So just play with your knobs, your up and down. So just remember that we have 3 esophageal constrictions, your CPJ, the thoracic or your aortobronchial constriction, although this is not as narrow as the first and the third. The third, of course, is the EGJ, or your esophagogastric junction, because of the diaphragm. So when you go to the esophagus, again, put the lumen at the center, push the scope lightly, slowly. Keep your middle finger at the air or button. Suction your fluid, your debris, while keeping the lumen inflated. Start noting for your abnormalities, for any mucosal lesions, for your presence of varices. So when you go into the EGJ, you push the scope gently. Because sometimes if you just push it with force, you can see your stomach already, or if the patient has hernia, so you might have perforation. So at the stomach, again, keep the lumen at the center. Follow the greater curvature down to your pylorus. Again, start to note for your abnormalities. And once you see your pylorus, sometimes the pylorus is contracted. So you time the push of your scope. You say push it gently. So this is the first part of your duodenum. It's very short. So when you see the bend that's towards your D2, so this is that it's a sharp bend. So push your scope little past the junction with your big wheel towards you. So when you hear your instructors say big wheel towards you, so the scope is going up, looking up. And then small wheel away, it is towards to the right, while pulling slowly. While you pull the scope slowly. So that's shortening of the scope. So once at the D2 lumen, you can now withdraw. You can start your examination. So you should see the 4 quadrants. So up, down, left, and right. So spot and blind spot is your D1, or in posterior of your stomach. So this is your J maneuver, or your retroflexion. So this is to assess the cardia and the fundus. So again, how do you do this? You pull up. So big wheel towards you while you push your scope slowly. So magre-retroflex ngayon yung scope nyo, looking up. So you should see the scope, of course. So you should also see or note the incisura. This is another blind spot. Not the cardia, slowly pull the scope while you maintain the big wheel towards you to look at the cardia. And if you want to go look closer, you pull. You pull it. To end your assessment of the cardia, you put the big wheel on neutral and then pull slowly to assess the body and the stomach. So now we are at the esophagus. So note this part. This is the transition. This is the gastric mucosa. This is the esophageal mucosa. So you look for your changes, for your Barrett's and other lesions, for your varices. You can see your varices here, of course. Slowly inflate the esophageal lumen. Slowly pull the scope. Again, look at the 4 quadrants so you can assess everything. If there are debris or pulled fluid, you have to suction those debris. So at the CPJ, note the level from the incisors and then remove the middle finger from the air and suction the saliva and debris.